Hey, thanks so much for joining us today. We're glad to have you on Georgia MemoryNet Insights today. We have a treat for you. It's Dr. David Loring, who's a neuropsychologist, works with the Emory Goizueta Brain Health Center. And so we've had him on a couple of times before. We'll tell you how to get to links of his past talks, which included topics such as clock drawing and also competency versus capacity, decision-making capacity. Both those were great talks, and so we're excited to have him here today. These are going to be experiences drawn from his own patients that he sees as a neuropsychologist. And so we're really excited to do that. There are no disclosures. He's going to quickly show you some information about how you can get credit for today's events, and then we'll turn it right over to him. Thanks, David, so much for joining us. We appreciate you.
Okay, well, thank you, Dr. Johnson. It's always a pleasure to present to this group. Just a little disclosure statements in terms of the accreditation and information regarding how to obtain credit. We have just a little bit of a background. We're going to take a quick little poll. It's always of great interest to see kind of the backgrounds of the people who are attending today. So Kim, can you go ahead and launch the first poll for us, please?
And the poll is launched and we're getting responses right now. And let's go ahead and close the poll and we'll show the results.
Lots of others. My favorite.
That's good though. That's good though. Lots of physicians, several nurse practitioners, registered nurses, PhDs, social workers, and some others. So thanks so much. And let's see, there we go. And that's backwards.
Yeah, I wanted to launch one more poll right now, if I could, please. We're going to be talking today about the issue of cognitive reserve, and I just wanted to get some sort of background as to what people might think when they hear the term cognitive reserve. So Kim, could you go ahead and please launch my first poll?
And that poll is launched and we're waiting for responses right now.
Yeah, so basically, what's the best described cognitive reserve?
And we've got about a half of the attendees. We've got about a half of the attendees. We'll just give it one more second.
Okay.
And there we go.
Good. Everybody's on top of it. I guess we can close the presentation down now. Seriously, though, the presentation today is going to talk about cognitive reserve because it's really an important concept and an important thing that happens. It helps me and provides a little bit of a challenge sometimes in terms of our ability to do assessments. Kind of the formal definition is the ability to compensate for cognitive change, relying on exceptional baseline abilities. So this might be an individual who's an architect that when we look at the visual spatial perceptual abilities, been doing it for a long time and is going to be good at our tests, even if there might be some decline, or alternatively adapting some alternative strategies to kind of arrive at a correct task solution. You know, in the clinic, what we do is we informally estimate it by level of education or taking a look at the occupation, what they did for a living. One of the advantages of the neuropsychological testing that we do is that we employ demographic corrections to really formally adjust for this background. And this is probably similar to that point that with MoCA testing, you'll give to somebody if they have a high school education or less. But this is a little bit more systematic and more formal when we do it in our neuropsych testing. Because of that, we always think that our neuropsychological testing provides really increased sensitivity to cognitive change. And in fact, that is true, but we have a problem of this cognitive reserve contribution because high functioning individuals may be in the normal range. There can be a decline in function, but they're still considered normal when we take a look at our test results. And when this happens, fortunately, the neuropsych test results themselves provide an objective quantitative baseline against which down the road comparisons can be made to take a look at the issue a little bit more objectively and with a little bit more precision. I'm going to present two cases that come from my own personal clinic. One of them is a PhD bench researcher, and the other one is a physician. Now, the 67-year-old researcher comes into the clinic with standard kind of complaints of memory decline, naming difficulty, and increased distractibility. I kind of like the following one. He had trouble recalling research papers that he was reviewing in order to keep up with the literature. So that's kind of a unique subjective complaint. When we talk to the wife, family, they haven't noticed anything at home, and there haven't been any work-related issues either. So the degree and the extent of the memory impairment, if it occurs, is not clearly evident to everybody. He reports that these memory problems have been going on for a couple of years now. He was educated in India, and this always makes our neuropsychological testing a little bit more complicated because our test scores even are based upon normative standards of people educated in the United States and also people whose initial language is English. Kashmiri was his native tongue, and he said that he also had word-finding difficulty back in his native tongue, which was potentially relevant. I'm going to go over a series of slides that show some of the neuropsychological test results. And our test results are, we have raw scores and standardized scores. Probably the easiest thing for us to interpret today is going to be some of the percentile values, but I'll kind of bounce around a little bit. When we test naming, we use pictures, as you can see down here, and patients are simply asked to identify, name the picture for me. You can see his score was at the first percentile, and we take a look at the recognition where they're giving cues in order to facilitate recall. There's a huge bump up in performance. Now, that's hard for me to interpret clinically because I don't know if that's because we're doing English testing and his native tongue was Kashmiri, or it might reflect some of that deterioration in native language naming ability. Importantly, however, the two verbal fluency tests that we rely on very heavily, that is the ability to generate words that begin with a particular letter of the alphabet, or the ability to generate various different animals, were well within the normal range. And I'd like to note here that all the percentile values that I'm reporting here, these have been demographically corrected for both age and for educational background. Take a look at memory. Two tests that we use for verbal memory is kind of learn a list of words over repeated trials and see how quickly they learn, and then how well they can retain the information. And we take a little bit a look at story memory as well. Learning the word list over trials, terrific, 90th percentile, 75th percentile. And we take a look similarly at the ability to recall words from the paragraph. That's still in the normal range and remains kind of in the low normal range when we do that demographic correction. When I do neuropsychological evaluations, particularly in the context of possible memory change associated with dementia or early dementia, obviously memory is very important, but executive function is the other area that I really take a look at very closely. The tests that we use here are kind of a card sorting test. It's called the Wisconsin, but basically the subject or the patient is presented with a word, or rather a card that could be sorted into multiple different categories. So you can sort it to red, you can sort it by number, or you can sort it by shape. And it depends on whether the answer is correct or incorrect. That feedback guides the ability to kind of generate a new hypothesis to come up with a correct solution. I already talked about word generation. Trail making B is going to be familiar to you if you give the MoCA, because this is the number, letter, connect the dots test. So 1A, 2B, and so on. So across all of these three measures, no suggestion of any cognitive impairment that we see neuropsychologically. This notation of greater than 16th percentile merely means that it's not at the 16th percentile, but rather the normative database that we use in order to evaluate its location is not so terrific. So these were the impressions. These are what I was taken from my reports. Number one, confrontation naming is impaired, likely due to cultural and educational factors rather than early disease expression. Two, normal learning and memory is present across multiple tasks. Number three, normal performance is present across measures of executive function. Four, self-reported depression and anxiety were both in the normal range. 5, this is considered a normal neuropsychological evaluation. Sometimes neuropsychologists have a tough time saying this is normal, but I concluded that this was a normal evaluation. And then I included this final boilerplate type statement that I always include. These data will provide a baseline against which future evaluations can be compared should there be any concerns of atypical memory decline in the future. So the second patient is also 67 years old. He's a physician. He comes in with somewhat of a similar story. Subjective memory complaints, judgment, general problem solving. We interview the wife to ask if she's noticed anything. She said, well, maybe a little bit, but I think it's just normal aging. I'm as bad as he is with respect to some of the things that you're asking. He retired a few years ago, in part due to the frustration in learning the electronic medical record system that was recently introduced to his practice. He comes in, though, with legitimate concerns. He has a very impressive family history of dementia, and the grandfather at age 62 and 2 aunts also in their 60s. He's 67-year-old, so he has a heightened concern with respect to his perhaps personal risk. I'll run through some of the same tests that we had before, going down the test real quickly. The naming, again, this is age and education dependent. 73rd percentile, 75th percentile for word generation, and animal name generation is terrific, 96th percentile. So the next, I add here a few tests that I didn't show you with the first patient. We look at visual spatial functioning in a number of ways. One is the Ray complex figure. And they're simply asked to copy that without any further instructions. Line orientation is shown here, where there's 2 lines that are presented to the individual, and they have to pick out the numbers of the corresponding band shape that we see here that are pointing in the same direction. And then simply this block design task, where they're given blocks that have 2 sides red, 2 sides half and half, and 2 sides white, and asked to construct designs like this. As you can see across all of these visual spatial tasks, normal scores we see. Real quickly through the memory, normal, normal, normal. So verbal learning is all good. Also includes spatial learning. So the ability to recall this complex figure that they drew. 99th percentile, pretty terrific. And the ability to recall more simple designs is normal, both for the overall and the demographically corrected score. Going real quickly to the frontal executive component, we have again the card sorting and the trail making. You can see all these scores are high, normal range. So my impressions for this gentleman were in fact very similar to what we did with the initial one. I said, this is a normal neuropsychological evaluation with normal memory function observed for both verbal and nonverbal material, and normal frontal lobe or executive function performances. No significant depression or anxiety symptomatology were reported. The pattern of preserved cognitive function across multiple tasks suggests that his concern for cognitive decline reflects the concern resulting from the positive family history rather than reflecting a mild cognitive impairment as a prodrome to dementia. These data will provide a baseline against which future evaluations can be compared should there be any concerns of atypical memory decline. So Kim, can we pop up the next poll, please?
And the poll is launched and we're waiting for responses right now.
Yeah, so one major benefit of neuropsychological testing when evaluating patients with subjective memory complaints is
in addition to your opportunity to answer poll questions, there's also a Q&A box. And so I'll be monitoring that and looking for your questions that you might enter before we're done, but we'll have some time for questions at the end as well. We're at about 64%. We'll give it just a couple of seconds more. And now we're at 72%. I'm going to go ahead and end the poll and I'll share the results. And everybody should see the results right now.
okay, great.
David, do you have a comment on answer number one? It rules out Alzheimer's disease entirely. We got 0 for that.
Well, that will be clear how wrong that answer is as we go and take a look at our follow-up evaluations on these two patients.
I'll stop sharing the results and back to you.
Okay, so here's our PhD researcher. He's referred for a follow-up testing. So you can see, again, we have this poor percentile value for naming. Fluency here is good. The animal naming is bad. But let's take a look against performance that we saw previously, and it helps to make this contrast. Still at the first percentile, but we have kind of like a 4-point decline in naming. A pretty big decline, still in the normal range, but from the 45th percentile to the 34th percentile. But even more striking is the change that we have in terms of the ability to generate animal names. We took a look at memory next. And again, if this were the single time that I were seeing this person, we'd take a look here at these percentile values and say this probably reflects normal memory performance. This recognition is down kind of in the very low normal range, but still in the range that we would consider to be in the normal. So that what comes to light, however, is having that objective baseline against which to make that comparison. Even though the learning had not really gone down, you can see the ability to retain information over time. So it's the difference between learning and memory, where we have memory has declined pretty substantially from 11 to 8, from 76th percentile to the 39th. We also have similar declines, though less for the story memory and very strongly for the recognition component that we have here. We take a look at the frontal or the executive functioning. Again, a quick cursory look at the percentile ranges would suggest normal functioning. And again, if this were a single assessment, that's what I would infer in my report. But what we see is the decline since we have this valuable baseline now against which to make that comparison. I talked real briefly about these norms not being terrific necessarily for categories, but you can see all 6 categories were obtained previously, and that's declined to 2. We take a look at the number of errors that were made trying to arrive at that solution, we can see that it's declined or increased rather significantly with many, many more errors. Finally, we take a look at the decline in this trail making Part B performance. That's a number letter connect from the 92nd percentile down to the 34th percentile. So we have a situation of decline that we see overall. So if we take a look real quickly at kind of what I was reporting in my summary at the end of my report, say overall performance is in the normal range. However, there is a consistent pattern of mild declines in executive function and memory reflecting mild interval change in neuropsychological status. So this together with the subjective findings suggest mild cognitive impairment. So we're making that inference based upon the interval change score rather than any particular threshold interpretation. So when it goes back to the neurology clinic here at Emory, they do all the current workup. The CFS was essentially normal. There's mildly elevated tau, which was not necessarily interpreted as indicative of an Alzheimer type or not. MRI revealed marked medial temporal and hippocampal atrophy, and the discrepancy or the asymmetry was of particularly diagnostic importance to the neurologist. And when we take a look at the genotyping, there are 2 E3 alleles, which confers an average AD risk. It's not elevated or reduced right there. So this individual was diagnosed with having frontotemporal dementia rather than Alzheimer's disease, making him kind of ineligible for the monoclonal antibody treatments that are currently given to people with mild cognitive impairment due to presumed Alzheimer etiology. So let's take a look at our physician. Again, it was a little bit of a longer interval change. Just the problem that we sometimes have in neuropsychology land is kind of a bracket creep because we have norms that are typically based on 5-year intervals. And as you go from one to another, even though there can be a small change in the raw score, it can be associated with a larger percentile change. So it's always important for us when we do our interpretation to look at some of this raw score differences. So looking simply at the naming tests that we have here, again, the quick cursory review across all the scores are normal. Nothing to be concerned about. And again, I remind you that the percentiles that we're reporting are demographically corrected. What we see, however, is a decline mostly in this animal generation in a minute from the 96th percentile to the 45th. And this is reflected in a 10-point decline, which is rather significant decline in terms of this functioning. Here are the scores initially on his visual spatial perceptual abilities. And we can see a small little decline in copy performance, a bigger decline in line orientation, and this block design comes from the 75th percentile down to the 50th percentile. So these are not large declines, but they're consistent across all the tests that we give, which is one of the reasons we like to give multiple tests of a particular construct. Memory, again, seems to be pretty much in the normal range, but when we take a look at interval change, you see a little bit of decline in the story memory, a little bit of decline in learning. Again, not terribly striking, but it's consistent. If we take a look at our design memory, scores very solidly in what would be called broadly the normal range. But again, the comparison what is really bringing out the valuable information with this evaluation. We have a decline from 26 to 21.5. The percentile change is not that remarkable due to that bracket creep I was talking about a few minutes earlier. But the memory for more simple designs, again, has declined from the 50th percentile to the 25th. Again, 25th strictly is considered to be in the normal range, but it's this interval change that provides really the meaningful information. The frontal and executive tests all look really good and in the normal range. When we took a comparison, there's not a dramatic change in any of these scores. So my follow-up interpretation for this was this is a normal neuropsychological evaluation based on concurrent normative levels. Mild interval declines were noted on multiple measures, although the word list learning remained essentially unchanged. There is also a decline in animal fluency since prior testing. However, there is a consistent pattern of mild decline suggesting mild interval change in neuropsychological status, which together with subjective findings reflects a mild cognitive decline or a mild cognitive impairment, normal levels of depression and anxiety. So when he goes into the clinic for follow-up, again, the genotyping is done. He has one E3 allele, one E4 allele, positive CSF biomarkers for Alzheimer's disease. So he's given a formal diagnosis in the neurology clinic of having MCI, Alzheimer's etiology, and lecanemab infusions were initiated for this individual. So real quickly, we're winding down. Kim, if you could pop up the final poll, please.
And it's coming, and there it is. The poll is open.
Yeah,
Welcome
so why
in.
might highly educated individuals with strong cognitive reserve still appear normal on neuropsychological testing despite early decline?
And we've got about 20% of the answers so far. David, while we're waiting for answers to come in before we share the poll, you can just check on the Q&A. There's one question that we'll tackle when we're done with this.
Okay, I'm not quite sure how to do that, so you'll have to help me.
I will help you with that. Thanks so
Thanks.
much. And we're at 66%, and I'll go ahead and end the poll and share the results. We got a split there.
Yeah. Okay, good.
I'll go ahead and stop sharing.
Yeah, so kind of the case summaries. I think we had two individuals with really high cognitive reserve and subjective cognitive complaints. They were normal on our neuropsych tests, so they're going to be normal on the cognitive screening measures, just about anything you use in the clinic. And like we'd like to think as neuropsychologists that, you know, we have super tools in our toolbox that are sensitive to cognitive change. And the fact they are, sometimes the amount of cognitive reserve kind of masks the ability to be able to find and confirm results. But in these cases, you know, it provides objective data, so at least we can do follow-up evaluations, because like so many degenerative conditions, they better announce themselves over time to take a look at that. So kind of my conceptualization is, individuals with high cognitive reserve don't just have more brain power, but they have more mental pathways to solve the problems, a larger toolkit. So I saw this analogy, it's like knowing the surface streets in Atlanta. There's lots of different ways to skin a cat. And if you are familiar and you have those things at your availability, you're able to use those and kind of compensate for the problems that otherwise would slow you down with respect to overall efficiency.
We'll go ahead and leave this on for how to claim credits. And thanks so much. We're going to be sending out evaluations to you and appreciate that. So let's go to some questions. The first question is from Antonio Rios. He asked this question about midway through. So you had only presented the first part of the first patient and not the follow-up. And so his question is, I imagine with the result of normal testing, our PhD bench researcher likely wanted more answers related to his subjective memory issues that are affecting his work. Tell us a little bit about how that conversation was and what motivates people to come in, and maybe sometimes they're not reassured by things look okay now.
Okay, I missed a little bit of that question, so I'll give you a long answer and hopefully touch on the important points. One of the important things of neuropsychology testing I tell our students all the time is the reassurance of normality. I mean, you can't prove the null hypothesis, but I can demonstrate frequently that a person's normal. These are cases that are a little bit different because most of my normal patients never come back to me for follow-up evaluation because they're normal and they don't have that progression and that concern, and that reassurance is great. These are cases that came in that, despite my evidence of normality, continue to have memory problems. I guess it does kind of emphasize the point that you need to take subjective complaints seriously because they oftentimes reveal things that are of concern. But I will say, I'm old enough to have subjective cognitive complaints too, and I need to reassure myself sometimes that this is part of normal aging. So providing the reassurance is really helpful in most cases. It's the difficult ones are the ones that come in with, like I said, their education, their occupation, they know what they're doing. I guess in retrospect that the researcher who had trouble synthesizing his research reports that he was keeping up with the literature was a very meaningful subjective complaint.
Great. I'm going to go on to the next question. It's from Charlene Jeffers. When would you consider using a reliable change index? Not everybody might understand the question, so a brief detail.
The reliable change index is a approach that neuropsychologists oftentimes use because, unfortunately, our tests, unlike blood levels or things like that, have a certain amount of error associated with it, either due to time of day or retest reliability. It's not the same. So the reliable change index was developed to take a look and see how far do the scores have to be so you are comfortable that the change that you see exceeds what can be attributed to kind of random or more random variation. We have all of these reliable change indices at our disposal to help guide us. Two issues though, and one is you can have real change that reliable change indices don't see, because sometimes in the literature, authors say a reliable change score is a clinically meaningful measure, where in fact it's just a statistically reliable measure, and there's a little bit of a disconnect there. I think most of the time as we're doing like follow-up evaluations for some of our surgical programs, those guide us, but again, you can have meaningful change that doesn't show up because even the reliable change index itself is a little bit like statistics. So you can pick one that's a 95% confidence or a 90% confidence or an 80% confidence. And I learned long ago in my life as an epilepsy neuropsychologist, a mother coming in telling me that her son has naming problems. And the Boston naming test, the picture test that I showed you, it didn't have a reliable change index. So she said, well, you're wrong. And she was wrong. I was wrong. She was right. Just because it didn't have that 80%, maybe we should use a reliable index of more likely than not. I mean, it's something that's interesting to talk about among neuropsychologists. But the short story, the reliable change index is a valuable, but it's just kind of a index that helps guide clinical judgment and inference.
Chad Hales asks, why does normative data / educational status not take this cognitive reserve concept into account when providing scaled scores and percentages?
Well, I guess the quick answer is that we do, and we use education to depend that, and that's our best measure. There are some approaches that have been used but not widely implemented that will use kind of a pre-morbid estimate. What we do in full neuropsychological workups is we try to have an estimate of pre-morbid function by taking a look at the ability to pronounce atypical grapheme to phoneme words. And what I mean by that is you have a word like paradigm. If you haven't been exposed to that background, you'll say paradigm when it comes across the read. So that belief or that approach kind of equalizes the variability in terms of educational background and so on with a more objective measure. Unfortunately, that's been discussed in some research protocols, but unfortunately has not been more widely implemented with respect to the normative database generation.
Thanks so much. I wanted to point out that the phrase that you use to get your credit for CME is slightly changed. It used to be attend and the number, now it says certif and the number. And so go ahead and do that. Thanks in advance for filling out your evaluations. And we're going to end with Carolyn Clevenger's question about the Salvador Dali clocks and what exactly you intended by that warping of time and space in reality.
Yeah,
so,
that's the disintegration of memory, and that's something that we all face both with normal aging and with pathologic aging. So just lets us be happy for what we got.
Great, thanks so much. A wonderful session. Again, we're going to put in, we're going to get to you as well, the link that you would need to see and view past GMN sites. You can also check out Dr. Loring's previous discussions of clock drawing as well as competency versus capacity. Both of those are fascinating, just like today's was. So thanks so much for joining us today. See you next time. Thanks again.